and we can get started with our next wonderful presentation, which is from Jennifer Goldman, a pharmacist and a professor of pharmacy practice at the Massachusetts College of Pharmacy and Health Sciences.
Okay, so everyone is here. I wanted to have an opportunity to say hello before I start sharing my slides. And thank you for coming. I am today talking about something that I get tons of questions on all the time, and that's the GLP-1 receptor agonist. And I am joined today by George Pavlakis, who is graduating this year. I met George a few years ago in his 4th year, and he reached out to me about working on some research. And this topic is something that we both thought was of great interest. If anybody's interested in getting a copy of the paper, please email me. So George actually did all of the research, wrote all of the big first draft. I did very little editing of this manuscript that George worked on, and did all these amazing tables. And I know obesity medication is such a big topic, but so is diabetes. And so we wrote a paper titled Diabesity, and that's basically what we're going to be talking about today. I need to disclose to you that I am on the Speakers Bureau for Novo Nordisk, Lilly, Abbott Diabetes, CQR, Xeris, Sanofi, and Amgen. George has nothing to disclose. And I am going to be using generic names throughout this presentation. This is a list of the brand names, just so you can put it together if you need to know what those are. So the learning objectives that I'm going to cover today is I'm going to describe the American Diabetes Association Standard of Care in Diabetes 2024. Those are available online for you for free. And we'll discuss the mechanisms of action of the current agents that are preferred by the ADA, and that's for the management of diabesity. We'll summarize some future therapies and novel mechanisms, and George is going to cover that exciting information. And I'm going to tell you about a case. So with that, I'm going to have you use your chat field for just a couple of questions right now. I'll ask you the questions again at the end, and we'll see if there was any value in any of the information we provided, and if we have increased some of those answers. And the American Diabetes Association Standards of Care 2024 recommends which of the following agents for the highest efficacy for glycemic control and weight loss. Pharmacists are such a smart group. Excellent. Will this poll share?
Yep, I can share it as well.
Okay. Excellent. So 85% said semaglutide. Let me close that. Which of the following is one of the mechanisms of action for the highest efficacy for weight loss from the GLP-1 receptor agonist class of glycemic agents? Which is the mechanism? All right. Shall we end it and share? Excellent. So kind of a mix, but 67% increase in satiety. Which of the following is a proposed mechanism of action of the pipeline drug that's being studied for diabesity called retatrutide? Is it activation of glucagon, GLP-1, and GIP, activating the amylin receptors, inhibition of glucose production, increasing insulin secretion, or inhibition of DPP-4? All right, I think we can stop this one. So we get about 47% with the top one, and then a mix of the others. So we'll see what happens. George is going to do a good job explaining that. We'll see if we can get that higher than 47%. So I'm going to briefly review type 2 diabetes pathophysiology. But just as a reminder, I'm sure I know a lot of you listening. I'm hoping I have a lot of you as students, and please feel free to throw that in the chat. I've been practicing for 34 years and am currently, I developed and direct the cardiometabolic practice at Wildlife Medical in Peabody. I've been there for 12 years and spent 15 years in family medicine before that. And I'm a professor at MCP, as you all know. So as a brief review, just to truly understand the pathophysiology of diabetes and where the drugs that are used for diabetes actually work, is, let's just say, I know lunchtime is coming, right? It's 11 in the morning. And let's say you don't have diabetes, nobody has diabetes, nobody's going to faint from hypoglycemia. Why is that? Because your body is so smart that your liver is going to release some glucose to keep your blood sugar up. Your alpha cells of your pancreas is going to release some glucagon, also keeping your blood sugars up. The beta cells don't make insulin when you don't need it at the moment. You have some background insulin, but you're not going to be making a ton of insulin at that time. And so what happens is when you do eat food, you don't have diabetes, you eat food, and there's incretin hormones that are released from the L cells and the K cells of the gut, and that's called GIP and GLP. GIP is the newest incretin that has been identified and used in drug therapy, which we'll talk about. So those two incretin hormones are responsible for telling your beta cells, hey, we're eating now, make some insulin. And then we'll tell your alpha cells, we're eating, don't make any glucagon, we don't need it right now. Tells your liver, we don't need any glucose, stop making glucose. That will decrease postprandial blood sugars. And it also tells your brain, hey, start getting full. It slows gastric emptying so that you don't have high postprandials. So what happens, what's different when you have type 2 diabetes? When you have type 2 diabetes, a couple of things are happening. One is you have insulin resistance. So your periphery, your adipocytes are not sensitive to insulin. So you can see here that 10 to 15 years before you're diagnosed with diabetes, you actually have a very high increased insulin resistance. In response to that, because your body wants homeostasis, your beta cells will make extra insulin. So making that extra insulin to overcome that insulin resistance. And you can see in that blue line, that insulin level increasing. So you kind of live your life that way and you don't get caught because your blood tests are going to be normal. And simultaneously, you can see glucagon is still being released, but your incretin levels, those incretin hormones, are starting to decrease, and your beta cell function, pumping out all that insulin, is also starting to decrease. At this point, at time 0, you can no longer keep up with that insulin resistance, and your beta cells aren't working, so you can't make enough insulin. What happens once you have diabetes and you have that insulin resistance across at time 0, those GLP and GIP, the incretin hormones, are no longer working. So when you have diabetes, now you eat lunch, what happens? Well, you eat lunch, and now instead of your liver stopping making glucose, and instead of your alpha cells stopping making glucagon, it continues to produce this, even though you don't need it, and you don't have enough insulin, and you're highly insulin resistant, and because your incretin hormones aren't working, you don't feel full. So that's another thing. So that's why you hear people complain of just never really feeling full. And the other thing is people with diabetes actually have rapid gastric emptying. So they have increased postprandials. And if your incretins aren't working, you don't slow gastric emptying. So now you're just set up to having continued hypoglycemia. And so this is where the big targets are for the incretin hormones, particularly now we have a new one, which is the twin incretin. So what is GLP-1 responsible for? So that's the one made from the L cells of the gut. Decreases
Jennifer?
Yeah.
Jennifer, can I interrupt for 1 second? So your audio is a little garbled, and we're wondering if you turn your video off, that might free up some bandwidth.
Oh, good idea.
And I think you can still screen share, and yeah,
Excellent. How's that?
that seems better. It's been wavy. It's gone in and out a little bit, but let's hope
Oh.
this improves it. Thank you.
Thank you. So what GLP-1 will decrease food intake, increase insulin secretion, decrease glucagon secretion, delay gastric emptying, so you don't have that postprandial. Now, the addition of the GIP, and that's the newest incretin, also is decreasing food intake. But what is particularly special about the GIP is about 33% of insulin secretion is from GLP-1 and 67% is from the GIP. The other thing is we actually have GIP receptors in our adipocytes, so in our fat cells. And by stimulating that GIP receptors, you increase insulin sensitivity and you make a more efficient fat cell. So that also leads to weight loss and other positive benefits. So that's basically how they work. Now, I had mentioned to you that the ADA standards of care are out. They're available in an app. They're updated regularly. And beginning in 2018, it became a living document. So it's updated as new data comes out. So you can take a look at that. So just as a reminder, what we're going to be talking about A1C as a target, as a primary target in these clinical trials. For most people, we're looking for an A1C of less than 7. You might have younger, healthier patients. You're looking less than 6.5. You might have people who are older, they're not ambulatory, where you might be looking for less than 8. But most people, the target is less than 7, and you'll see that that's what we're looking for in those clinical trials. So what about obesity? Y'all know that the demand for effective therapies has certainly increased, and weight loss is critical to both prevent diabetes, but also prevent the obesity-related complications and cardiovascular disease and actually certain cancers. So we know that it's influenced by genetic predispositions as well as environment and behavior. So according to the 2024 standards of care, obesity management delays progression of prediabetes to type 2 diabetes, and weight loss can actually reduce the need for certain drug therapies. So what are some of the updates that were in the recent diabetes guidelines? Use person-centered, non-judgmental language. So it's person with obesity. So we're no longer going to say a morbidly obese person. It's a person with obesity. And in people with type 2 diabetes and overweight or obesity, weight management should be a primary goal along with glycemic management. So it's not only glycemic centric in this case. So we know that the data shows that 3 to 7% of baseline weight loss improves glycemia, and sustained loss of greater than 10%. Obviously, you'll have better benefit. The recommendations are we individualize that treatment for people who have obesity. So although George and I are going to be talking about all the drug therapy, obviously, lifestyle changes make a significant contribution to patients. So what can we do as pharmacists? We can certainly make recommendations when we're choosing drugs that minimize weight gain. So avoiding sulfonylureas, avoiding glitazones, things that do cause weight gain, and just prioritizing drug therapy that helps with weight loss. Now, one of the recommendations in the ADA guidelines, the ADA standards of care right now, is obesity pharmacotherapy should be considered for people with diabetes and overweight or obesity, along with lifestyle changes. So they strongly are recommending that with should. And they are the preferred pharmacotherapy in the standards of care is a GLP-1 receptor, or what I had talked about earlier, the twincretin, the dual GIP-GLP receptor, and the ones with the greatest weight loss, semaglutide or tirzepatide, and I'll specifically show you that data. So when you look at the algorithm for the treatment of diabetes, This is sort of what it looks like. I'm going to just pull out so you can see it a little better. We're going to concentrate on these two on the right. And that is, in general, higher efficacy for reaching your glycemic goals. The very highest is considered high dose dulaglutide, semaglutide, and tirzepatide insulin in the combination. So that's specifically for glycemic control. But what we're talking about today is diabesity. And so when we're talking about diabesity, we're going to choose therapies that have very high efficacy for both glucose and both obesity. And very high would be semaglutide and tirzepatide, the highest of all of those options. So GLP-1 receptor agonists, high to very high efficacy. They work in the presence of hypoglycemia, so they have a low incidence of hypoglycemia. When would we see hypoglycemia? Maybe if we're using it in combination with sulfonylureas or insulin. In terms of weight, we have intermediate to very high efficacy, with semaglutide and tirzepatide being the highest. In terms of major adverse cardiovascular event benefit, the ones that do have that primary outcome data to prevent non-fatal stroke, non-fatal MI, and death due to cardiovascular disease is dulaglutide, liraglutide, and subcutaneous semaglutide. Exenatide once weekly and lixisenatide were neutral, and the cardiovascular outcome trial for tirzepatide has not read out yet, and I'll talk about that in a second. Neutral for heart failure, progression to diabetic kidney disease. There has been benefit with dulaglutide, liraglutide, and semaglutide. Semaglutide kidney trial was recently stopped early because of robust outcomes for efficacy. So, put a pin in that, because you may in the future be seeing some potential indications. In terms of dosing considerations, one thing we know that people with diabetes have chronic kidney disease very often, and there is no dose adjustments for these GLP-1 receptor agonists. Now the duals, so with the GIP, which currently is tirzepatide, is considered very high efficacy. Same with the no hypoglycemia, very high weight loss. MACE is under investigation. Heart failure is under investigation. This is one of the newer drugs, so those will read out. Same thing with the DKD, but importantly, there's no dosing adjustments that need to be done. Across the board, what we're going to ask patients, what I usually say is, do you have a history of thyroid cancer? If the answer is no, I move on. If the answer is yes, I'm going to drill down a little bit to see if there's a personal or family history of thyroid C-cell tumors. So that was seen in rodents. The other thing we do is we counsel on GI side effects and provide temporary mitigation techniques. So if we can, we start low, go slow. And, we're in New England, so I usually have a conversation, something to the effect of, if you're used to eating 3 or 4 pieces of pizza, you need to eat 1 piece of pizza and see how you feel. People haven't felt full in a long time. They don't necessarily recognize that feeling of fullness. And so to mitigate that nausea and the GI side effects, eating less or eating smaller meals. Recently, there's been reports of ileus, so bowel obstruction. So that is something I usually say to patients. Between that, pancreatitis, and gallbladder, there's a 0.6% incidence, especially when people have rapid weight loss, of having an acute gallbladder. But I say, if you're holding onto your stomach and crying and saying, ow, 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 you need to go to the emergency room. But I do have that conversation with people. So we have very similar, same recommendations with the twin creatine. The other thing, what's different here is with tirzepatide, and you need to let tirzepatide get to steady state, which is at 4 weeks. So any female using oral contraceptives for contraception, you'd want to use a backup method until you're on a stable dose for 4 weeks, or choose another alternative drug. So that's an important thing as a pharmacist to pay attention to. If you have a woman on oral contraceptives and you're giving them tirzepatide. So what agents are actually approved for obesity outside of type 2 diabetes? phentermine, orlistat, phentermine, topiramate, naltrexone, bupropion. I'm not going to cover all those. I'm going to concentrate on the drugs that we're using now for diabesity. But liraglutide, semaglutide, and tirzepatide all have FDA indications for obesity outside of type 2 diabetes. So those have that indication. So those three have a dual indication, so also for diabetes. Oral hydrogel Plenity is also an option. It's not considered a drug, it's considered a medical device, and I think we're soon going to see that potentially as over-the-counter agent. So current therapies we want to use, remember that part of the chart on the right, for very high weight loss, very high efficacy, we're going to be preferentially choosing semaglutide or tirzepatide. And so I'm going to show you, that's the data I'm also going to show you. So just a little history, injectable liraglutide once a day was approved in 2010 for type 2 diabetes, but then marketed for obesity under a different name in 2014. So that was the first incretin used that way. Then injectable semaglutide was approved in 2017 for diabetes, and then later marketed with a different brand name for obesity in 2021. So a dual indication. Now, tirzepatide, as you know, came on the market about a year ago, and just recently in November was approved by the FDA for obesity. So that also has a dual indication. So let's just start. I'm going to review a little bit of the semaglutide data. I'm not going through everything. So the SUSTAIN program is what they call all of the clinical trials for type 2 diabetes using semaglutide. SUSTAIN 6 was their cardiovascular outcome trial, so that you know. And there are other trials that are ongoing. There are other trials that have finished. They're in various phases. They may be unpublished, but very well studied. So across the board, the change in A1C from baseline in SUSTAIN 1 through 10 is noted here, as you can see. So you can see very robust A1C reduction, and there's a range depending on whether they got the 0.5 dose or the 1 milligram dose of semaglutide across the board, really showing superiority against all the comparators. And you see 1.3 to 1.7 or 1.8% reduction. So superiority truly are in all those clinical trials. The same thing was seen with body weight in the semaglutide trials, the SUSTAIN trials in type 2 diabetes. And you can see this is the change in body weight in pounds. So, really a range of about, 8 to 14 pounds. Now, just to point out the cardiovascular outcome trial in type 2 diabetes, they do have the primary indication for MACE reduction, which I had mentioned, 3-point MACE earlier. And you can see that going across the board, sustained with continued reduction over time. Now, the STEP program, the STEP program is the semaglutide clinical trials for obese or overweight. So specifically for obese and overweight, not type 2 diabetes, with the exception of STEP 2. So I'm going to pull out the STEP 2 trial for you. So STEP 2 trial was an obesity trial in patients with type 2 diabetes. So in the weight loss trials with semaglutide, very well studied. You can see steps 1 through 8. There's a step teens. There's cardiovascular outcome trial. So there is MACE reduction. They do have the MACE reduction. They met the primary endpoint of major adverse cardiovascular events in patients with obesity and no diabetes. So semaglutide in that case actually has that cardiovascular data. So let me just pull out the step 2. So this is the semaglutide, so the weight loss trial in patients with type 2 diabetes. It was a 68-week double-blind trial. And what you can see is at the highest dose, there was a 9.6% weight loss. And you see weight loss, really sustained weight loss, and very early on, decreased weight. And this, again, is in people with obese or overweight and diabetes. The percentage of patients who actually had weight loss is listed here. So at the highest dose, almost 70% had greater than 5%, almost 50% had a greater than 10%. And remember, in the standards of care, you know, greater than 10% is particularly special in terms of outcomes. And people who had greater than 20% weight loss at week 68 was about 13%. So here is the A1C reduction, and you clearly can see a significant A1C reduction in those patients who received semaglutide in both doses, with 80% reaching an A1C of less than 7 and almost 70% reaching an A1C of less than 6.5. So that was the semaglutide trials. With the SURPASS trials, that's tirzepatide. So their program is SURPASS program. So this is the trials for type 2 diabetes called SURPASS. And very well studied. Not all of the trials have completed. SURPASS, the cardiovascular outcome trial. Now remember, dulaglutide has the indication for MACE reduction. So tirzepatide is actually being compared head to head to dulaglutide in greater than 12,000 participants. So keep a pin in that one. That'll, we'll see that data in the coming years. So SURPASS 2 is actually the one that was compared to semaglutide. So I will kind of show you a summary and show you the SURPASS 2. So here is the summary, and you can see statistically significant reduction in A1C for the primary endpoint in all of these SURPASS trials. SURPASS 2, the one with the arrow in it, the second one, that was compared to semaglutide 1 milligram. And there was statistically significant A1C reduction with tirzepatide compared to semaglutide, with a 1.9% with semaglutide and up to 2.3% with the highest dose of tirzepatide. In terms of the body weight change in the type 2 trials, you can see this is the weight change in kilograms. So in the SURPASS 2 trial, I did the math for you to show you the pounds. And what we saw was statistically significant weight loss in those doses, with the semaglutide 1 milligram with a 12.6 pound weight loss, and the 15 milligram of tirzepatide, almost 25 pounds weight loss. Now, the obesity trials for tirzepatide are called the SURMOUNT trials, so the SURMOUNT program. And just like what we just saw in semaglutide recently, their number 2 trials, this is SURMOUNT 2, was an obesity trial that included patients with type 2 diabetes. So SURMOUNT 1, 3, 4J, CN, this is all obesity trials without diabetes. SURMOUNT 2 is the one that includes diabetes. So the SURMOUNT 2 primary endpoint was body weight change, percent of patients reaching a greater than 5% weight reduction. In the percent, they also looked at percent reaching 10%, 15%, 20%, and also the mean change in baseline A1C. So the change in A1C you can see is clearly, highly significant in terms of A1C reduction, but also it was early on. You can see at 3 months A1C reduction, and it was sustained across the trial. In the percent reaching their targets in the SURMOUNT 2 trial, almost 50% or slightly more than 50% actually reached an A1C of less than 5.7. And I just want to, point that out, that 5.7 to 6.4 is considered pre-diabetes. So less than 5.7 is quote unquote within normal limits. Almost 90% of people reached less than 7 and 85% or so less than 6.5, but half of those patients reached an A1C of less than 5.7, which would not have been diagnostic of pre-diabetes or diabetes on paper. Very significant weight loss that you see across the board. With the 15 milligram dose in the SURMOUNT 2 trial, it was almost 15% weight loss. in terms of participants reaching their body weight reduction target at 72 weeks, you can see also very highly significant. This is the 5%, 10%, 15%, 20%. So, you know, more than 50% reaching reduction of weight loss of 15%. 34% at the highest dose tirzepatide reached greater than 20% weight loss. So you can see why the ADA standards of care do have these agents as highly effective. So I'm going to bring George up now. I'm at the right place, right, George?
Yeah.
George is going to now talk to you a little bit about the pipeline and what's going on with the Diabesity and the pipeline, and really take you through it. And what I really want you to appreciate is this is a student at MCP graduating this year who did all this research and helped me write this paper. And, you know, he did most of the work. So take it away, George.
Thank you so much, Dr. Goldman. And thank you everyone for having me and allowing me the opportunity to speak to you all. So as Dr. Goldman mentioned, I will be talking about the agents in development and in the pipeline for diabetes and obesity together. And the agent I want to highlight briefly first is the one that's currently approved for type 2 diabetes, but being studied for obesity and is actually closest to approval. And this agent is oral semaglutide. And oral semaglutide is undergoing a current phase 3 trial, which is the OASIS-1 trial, and it's studying the oral formulation of semaglutide for obesity at a higher dose of 50 milligrams than its already approved doses of 7 and 14 milligrams for type 2 diabetes. So just briefly wanted to highlight that that is the agent that is closest to approval currently. Moving on, tirzepatide is the only twincretin, we'll call it, currently on the market. However, the pipeline is very vast with novel double and triple mechanisms on the way. And those mechanisms in development for type 2 diabetes and obesity include a mix and match of agonists, analogs, and hormones, including GIP, GLP-1, amylin, and glucagon, to highlight the main ones. Next slide, please. So I want to touch on the ongoing diabetes and obesity trials, specifically the ones that are in phase 3. So first we have the DREAMS-1, GLORY-1, and GLORY-2 trial, which include a novel combination of glucagon and GLP-1 receptor agonist, which is mazdutide. And GLORY-2, just to mention, is a continuation of the GLORY-1 trial, but it's actually studying the drug at a higher dose. And we'll touch on those results shortly. The REDEFINE-1 and REDEFINE-2 trial include a novel combination of cagrilintide and semaglutide, which is a double mechanism amylin analog and GLP-1 receptor agonist. Next, we have retatrutide, which is the triple G combination. It's glucagon, GIP, and GLP-1 receptor agonist. Going down the list, we have orforglipron, which is a GLP-1 receptor agonist. However, this is also oral, just like the oral semaglutide that's being studied. And then the SYNCHRONIZE-1 and SYNCHRONIZE-2 trial include glucagon and GLP-1 receptor agonists known as survodutide, which actually just recently advanced to phase 3 after showing very positive phase 2 results. Next slide, please. So I want to touch on the mechanisms of action. So glucagon is the one mechanism that we haven't seen approved yet. However, there are quite a few agents that are in development, including glucagon, such as the glucagon and GLP-1 receptor agonist and the triple G, which has glucagon, GIP, and GLP-1. And initially, many of the efforts that incorporated glucagon into the therapies focused on antagonizing the GCG receptor due to its ability to cause hyperglycemia through stimulation, through causing gluconeogenesis in the liver. But these studies were actually halted due to undesirable hepatic effects, such as elevated liver enzymes, and the focus was shifted to actually activating the GCG receptor. So next slide, please. So as Dr. Goldman mentioned, GIP and GLP-1 have many different effects, and including the distribution of GCG, GIP, and GLP all have overlapping effects. However, due to the tissues having different receptor expressions, these cause the mechanisms to have actually unique effects on each receptor. So GLP-1 and GIP regulate blood glucose and appetite through postprandial stimulation of insulin, delaying gastric emptying, and the activation of satiety pathways in the brain. And alone, GLP-1 may have more effect on appetite suppression and provide a little more glycemic control than GIP. However, in contrast, GIP has been linked to an increase in lipid metabolism, decrease in circulating triglycerides and free fatty acids, and also increases insulin sensitivity through its direct effect on the adipose tissue. But leaving those aside and actually focusing on glucagon, glucagon has been shown to increase energy expenditure and thermogenesis, as well as insulin secretion, increase in lipolysis, satiety, and also glucose production. And the mechanisms that incorporate GCG also have GLP-1 because GLP-1 actually combats the increased glucose potential of GCG. Next slide, please. And then additionally, amylin is another combination, novel combination that we have possibly coming. And an amylin analog actually mimics endogenous amylin, which is a glucoregulatory hormone co-secreted by our pancreas with insulin in response to food intake. And amylin actually inhibits glucagon secretion. It suppresses the liver's glucose output and also slows gastric emptying while acting centrally to decrease appetite. And unlike GCG, GIP, and GLP, amylin does not have any insulin secretory effects. And there is one actually amylin analog available on the market, pramlintide. However, the combination of cagrilintide with semaglutide is novel. Next, please. So I have this very detailed graph here, just highlighting these are the drugs that are actually approved for type 2 diabetes with or without an obesity indication. So you can see the one agent that's actually unnamed brand name is the oral semaglutide formulation that's being studied for obesity at the higher dose. And you can actually skip to the next slide, please. And just to focus really on the pertinent information, tirzepatide body weight reduction at the highest dose showed up to 22.5% body weight reduction. And the highest possible A1C reduction with tirzepatide was showing up to around 2.46%. And then moving down the list, oral semaglutide, the one being studied at the higher dose in development, showed a body weight reduction of up to 15.1%, with the highest possible A1C reduction of around 2%. And then going down the list to highlight some, the injectable semaglutide showed the highest possible body weight reduction of up to 16.1%, around that, and A1C control of around 2.1%. And then as you can see going down, liraglutide injectable up to around 7.4% highest body weight reduction with around 1.5% A1C reduction. Dulaglutide up to around 4.8% body weight reduction, and then 1.8 A1C reduction, and then exenatide up to around 3.4% body weight reduction with around 1.6% A1C reduction. Next slide, please. And now this other table that I made is also very detailed. And these are the drugs that are actually in development for type 2 diabetes and overweight or obesity. And you can actually skip to the next slide just to focus on the pertinent information. So as you can see, mazdutide, which is the dual glucagon and GLP-1 receptor agonist, showed a highest possible body weight reduction of around 18.6% at week 48 and around up to 1.67% A1C reduction at week 20. Moving down, we have the dual amylin analog and GLP-1 receptor agonist, which is cagrilintide and semaglutide. This showed a body reduction of up to 15.6% at week 32 and around 2.1% A1C reduction at week 32. And then retatrutide, which is the triple G, the glucagon, GIP, and GLP-1 receptor agonist, showed a body weight reduction, an average of up to 24.2% body weight reduction at week 48 with around 1.9% A1C reduction at week 12. Orforglipron, which is the oral GLP-1 receptor agonist, showed the highest body reduction of up to 14.7%, and then up to 2.1% A1C reduction at week 26. Survodutide, which is a dual glucagon GLP-1 receptor agonist, showed a body weight reduction of 14.9% at week 46 and up to 1.8% A1C reduction. And then lastly, danuglipron, which is also a GLP-1 receptor agonist. It's also oral. This one is actually currently in phase 2. It showed a body weight reduction of up to around 13% at week 32 with its highest A1C reduction, showing 1.57%. So we have some pretty great results across the board for the drugs in development for type 2 diabetes and obesity. And then the last thing I want to mention is the safety and adverse effects across these agents. So the efficacy and safety of the approved drugs are well established, with a majority of them being GI side effects like nausea and vomiting and other gastrointestinal upset. However, the pipeline agents are not fully elucidated yet. However, we can maybe infer that because the mechanisms are so similar to the ones that we already have approved, that they will likely have similar safety warnings and adverse effects. And of the approved GLP-1s and the GIP and GLP-1 receptor agonists, the most predominant side effects and adverse effects are GI related, like I just mentioned. And how we mitigate those is really by, like Dr. Goldman mentioned, mitigating with smaller meals and starting at lower doses and titrating up as tolerated. So as Dr. Goldman mentioned, if someone's used to eating 3 to 4 slices of pizza and they're starting a GLP-1 or a GIP GLP, maybe start with 1 and see how you go. And then lastly, hypoglycemia. It is minimal, however, it's more likely with concurrent use with insulin or sulfonylureas. But yeah, that's it. Next slide. And then I will actually pass it back over to Dr. Goldman. Thank you so much for having me again.
Thank you. Proud mama here, proud teacher. So excellent job. So, kind of summarizing things up as we get ready to finish is, we know diabesity is chronic progressive. Both of them are chronic progressive diseases, and we need to manage both. We can't do it in a vacuum. We have to treat both of them. We know that if we manage obesity, we can delay progression to type 2 diabetes, but there's also benefit of treating obesity in someone with type 2 diabetes. We should choose, weight loss agents that are preferred. And we know weight loss improves glycemic control. It reduces the need for certain drug therapies. We have a very robust pipeline. The treatment for diabesity right now, is limited. We know that the highest efficacy based on the clinical data that we just showed you was semaglutide and tirzepatide, but there's a lot of very exciting things coming that George just explained with the novel double and triple mechanisms. So quite exciting. I just want to tell you about one patient, and this is a poster that a group of my students presented at the ASHP mid-year meeting. And basically, I had a patient, this 51-year-old male with obesity. And I saw him, his A1C was somewhere around 9.3 or so. And he was on semaglutide, empagliflozin, metformin, and insulin, basal insulin. And I said, I was actually mentally getting ready to have the conversation with him about adding mealtime insulin because he really wasn't doing well. So at the time that I started the 2.5 milligram tirzepatide, what I did was I switched out his semaglutide with tirzepatide, the lowest dose, and I didn't change anything else. So I left his insulin alone, did everything. He had lost a couple pounds. His A1C was 9.5. So I started titrating his tirzepatide. And 3 months later, interestingly, remember he was at 9.5. 3 months later, and all I did was switch semaglutide 1 to tirzepatide 15. His A1C was 6.3. So certainly a bigger reduction than I expected. But look at the weight loss he had. So he lost such a significant amount of weight at that time. So to make a very long story short, his A1C is less than 6. He's lost over 100 pounds now. I had to stop all of his insulin. He's on 15 milligrams of tirzepatide, but I also had to cut his metformin and his empagliflozin dose in half. So doing very well. So a big success story there. So with that, I'm going to come back to these questions and see if we can get it 100% right this time. So the American Diabetes Association Standards of Care 2024 recommends which of the following agents for the highest efficacy for glycemic control and for weight loss. Are we able to put that poll back up, or are we going to use the chat?
I'm trying to put it up now, but it's
Okay,
the launch
great.
button.
No problem. Stay tuned, everybody.
For some reason, the launch button is grayed out.
Well, how about we have everyone post in the chat for this one?
What if I go back? Yeah, that was the first one.
Well, for this one, everyone's doing in the chat. We can try again. So
Oh, there we go.
everyone's voting for D, for that one. So we still have some stragglers with the glipizide with 1%. I'm hoping that was, oops, I did that by accident. So you're all absolutely right. You can share those results with 99% of you choosing semaglutide. So that is absolutely the correct answer. Semaglutide, spot on. Which of the following is one of the mechanisms of action for the high efficacy of weight loss from the GLP-1 receptor agonist class of glycemic agents? Do we have this post? So we have
Yes.
some.
For some reason, it's a delay.
I see. So there's a delay. So we got a lot of people voting in the chat, and excellent. Here's this. So I'll have patience for the next one, and we can have some patience. So we can share those results. 90% of you are getting that right. So remember, with that, centrally in the brain, we have GLP, GIP receptors, and helps increase the feeling of fullness so that you eat less. And we'll go to the next one, and I will be patient for that delay of posting this poll. I'll read, there we go. Which of the following is a proposed mechanism of action of the pipeline drug retadrotide? So this is George, so we have to make sure we get a high percentage right, because this was George's presentation. They're doing good, George. You did a good job.
Thank you.
All right, we can share those results. So 77% of you said the triple G. So retadrotide is triple G, the glucagon, GLP-1, and GIP. So the amylin receptor one, I think what you're thinking of is the CagriSema. So those 77% paid was the triple G. Excellent job. So definitely an increase from the 47% earlier. Very good. So what's the role of the pharmacist? What should we be doing? You know, patients are asking us all about this. So, you know, really, it depends on where you are, whether you're hospital system or community system or AmCare, wherever you are, this conversation is going to come up. I think what we need to understand and appreciate as pharmacists is helping recommend or choose drug therapy that treats diabesity. So not just glycemia and not just obesity, both of them. And that's what the evidence and that's what the standards of care recommend in terms of preventing type 2 diabetes and preventing the progression, preventing the complications associated with diabetes. So making sure if we see people on sulfonylureas, we see people on glitazones, we see people on drugs that are causing weight gain, when we know that it's an issue, making those recommendations. So with that, I am going to stop sharing and hope I can put my video camera on and we can address some questions. All right, so
we have some questions in the Q&A.
yeah, okay. As you've seen, Mass Health and other insurance are opening up their coverage of weight loss products. Have you seen any modeling projections or calculations of practice that can provide estimates of overall medical savings? You know, that's to justify the cost. Not as of yet. So I think what's particularly important is, you know, we all know that preventing a heart attack, a stroke, and a cancer and other things related to obesity certainly saves money. I think that's going to come. The pharmacoeconomic analysis is probably coming. Joy, there's concern about patients losing more lean muscle mass in addition to fat mass. Any comments on this? You know, I think that in the big picture of that, we have to make sure, audio is not clear again, you stopped my video. So I think what we need to make sure, Joy, is that we have to look at the big picture. And so we can't just have people losing weight without trying to have, you know, nutritional and other lifestyle changes. So if that is a concern, you know, they might need to do weight-bearing exercises and so forth. So I think that you have to have a benefit risk thought process for that. After exercising, would your insulin level go up? So what happens with exercising is you actually improve your insulin sensitivity in your periphery. So your insulin levels would only go up in response if you had a response, if everything's working, if for some reason you had hyperglycemia. So usually if there would be food, if there was some type of glucose coming. So usually that, you know, the benefit we see from exercise in the population is going to be from the insulin resistance, the decrease in that. Is there a relationship adverse effect of these GLP-1s on retinopathy? So Mary, the warning for retinopathy on these class of drugs is the same warning that you see in the insulin package inserts. When you have somebody with a baseline proliferative retinopathy in the background and you rapidly lower an A1C, so let's say they have very, very high A1Cs and you rapidly lower it, there is a small risk of worsening their retinopathy at that time. So in general, it doesn't appear to be that these drugs cause retinopathy or worsen retinopathy. It's a direct relationship of that rapid decrease in that A1C. So the same thing you're going to see with insulin. So what's the bottom line here? We need to be making sure patients get their annual eye exams. What are your recommendations for switching between products if there's a shortage or alternative? So here's what I do. Here's the thing. Let's just say I have someone on tirzepatide 15 milligrams and they can't get it this month. I'm going to ask the pharmacy, well, what do you got? You got 7.5? Do that one. That's fine. I'll write a prescription for 7.5. Because if you look at the differences across the doses in A1C reduction, but in the tirzepatide doses or semaglutide doses, or any of the doses, just like with the statins, you get the biggest bang for your buck with the first dose. You do have improvement with the increased doses, but I want them on that drug. So if for some reason they can't get that one, I'll use a lower dose or a different dose. I'm not switching between drugs if I don't have to. I have been known, if I have a patient on semaglutide, for example, and they can't get the 0.5 or they can't get the 1 milligram, I'll write a prescription for a 2 milligram pen and I'll have them count the clicks to get to the right dose. That's all off label, but I will do that. I do what I can not to switch between the agents and keep them on the dose. So if I have someone on the 2 milligram of semaglutide and they can't get it, and all they can get is 0.5, that's what they're going to get until the 2 milligrams available. So I hope that is helpful. Elaine, thanks for that question. Let me look at the time. How we doing? We have 2 minutes. Shut me off, David. I'm just going to keep talking in my rapid Boston talk. Do you know when is the appropriate time to increase the next strength of tirzepatide or semaglutide? So once a month. So once a month, you can increase to the next dose. Will oral semaglutide demonstrate cardioprotective effects in the future? So that is being studied. So there was safety in the cardiovascular outcome trial. In semaglutide, there was a reduction, but it was not the primary endpoint that they were looking at. So they can't claim that it has MACE reduction based on the first cardiovascular outcome trial. So that cardiovascular outcome trial to specific look as a primary indication for cardiovascular outcomes is not out yet. So put a pin in that one. which one of the meds is your first drug of choice to start a patient for weight loss management? So it's going to be the one I can get on their insurance. So, you know, I start at the top. And when I start at the top, that means tirzepatide or semaglutide. If patients are on Zepbound and soon go on Medicare, what happens? So I have gotten tirzepatide approved for diabetes. So, you know, if they're started on the weight loss version, if they transition to Medicare, right now that's going to be a problem, but that's being looked at right now in government and Congress. They're all kind of looking at covering those drugs. And I'm sure all the lobbyists are on them. So it looks like I'm going to have to stop in 1 minute. I don't know. I can, I'm happy to look at this. So is there adverse effects with concurrent liver disease? No, there actually is a lot of studies looking at this stuff to actually improve fatty liver disease.
And bring back to the stage Dennis Lyons.